Hey, welcome to another production from the Prolonged Field Care Working Group. This is a class on airway, airway management, cricothyroidotomy, and what to do after you have criced someone. A lot of times guys put in crics and they move on to the next treatment. There are many other things we can do, and we're going to be talking about those things. All right, so we're going to be going over an airway algorithm created by Lieutenant Colonel Bob Mabry and Rich Levitan, who got together and noticed that RSI and intubation in patients out in the field is probably not the best thing, especially if you don't have everything to support it, like your backup airways, your drugs, your drips, everything that goes with it. So if you look at some of Rich Levitan's recommendations, he has his residents go through 50 video intubations prior to even touching a laryngoscope. And he also has stress inoculation training through airway mannequins. They're not the best anatomical models, but they can be used for stress. And here's a little baby mannequin. Oh my God, what do you do? And you can inoculate stress that way. And then also practice your SOPs. Now, for us medics who don't get to the hospital very often, 6 to 8 live intubations per quarter is pretty much out of the question. You can try to get in there. I doubt you're going to get that many intubations on live patients. And this is what's recommended if you're going to be RSIing out in the field, that you try to do 6 to 8 per quarter. So that's going to add up over the course of a year, and most of us don't have time to do that. However, if you go on to a cuffed cricothyroidotomy tube or a cut down ET tube, that can remain in place up to 72 hours. So this is a very viable prolonged field care adjunct. And this is our airway algorithm that we're going to be using here in this episode, and what you should be using there on the ground, unless you have huge amounts of drugs for the drips that you can maintain those airways. So why Cric? Why not RSI or all those other adjuncts? Basically, having a tube in the back of your throat is going to be uncomfortable, and you're going to have a continuous gag reflex. Patient's going to be bucking. You're going to have to suppress that. Usually it's with opioid, fentanyl type drips or morphine drips. And if you have your hypovolemic trauma patient, you're probably not going to want to do that. Also, most of us don't even carry fentanyl to drip, so all we have are the lozenges, which isn't going to have the same effect that you're going to need for these intubated patients. Your training is probably not uniform or evaluated on live patients. If you went through the schoolhouse, you probably got graded on your procedure on a mannequin, and then you got to go to a hospital, and hopefully you got to do one or two in the nice setting of the OR, which is not the same as being out in the field by yourself without help. Skills maintenance for our size is not going to be likely for most of us medics with all the other admin requirements we have going on. Getting into a hospital 4 times a year and trying to get those intubations with the massive amount of medics that we have out there is really not realistic. So there's other techniques that we can talk about. Oxygenation. Most of us don't carry oxygen. If we do, we have one little or two little D cylinders. Maybe you have a concentrator that's 60 to 80% FiO2, and so you can try oxygenating your patients if that's something that can work for you. But usually, if you need to take somebody's airway, you're going to have a more definitive thing than a nasal cannula or just a non-rebreather. Then there are supraglottic airways like the Kings and the LMAs. They're not going to be super secure for evac, and they still may allow aspiration. It's also another thing to think about. Imagine right now if you took a King LT or an LMA and you shoved it down the back of your throat. That's going to cause most of us to gag. So if that gag reflex is still there, then you're going to have to use all the drips and everything like you would just for an ET tube. So it's something to think about. RSIing your patients requires paralytics to suppress the gag reflex, and then it requires you to maintain those skills so you don't do damage or mess up on your patients. Rapid sequence airway, probably going to need paralytics, and delayed sequence intubation, you're still going to have to maintain the analgesia drip, just like we're talking about with ET. So awake intubation, that's something else that you can go online and search about. it's not going to be good for our patients either. So everything really does lead back to Cric for our most secure definitive airway. So here we have some indications for the Cric. The first two are the ones that most people are very comfortable with. If you have massive facial trauma or burns of the face and airway, most guys are pretty comfortable with taking a knife and cutting the neck. Now, if you have something like your chest wall injuries, your flail segments, your contusions that patients can't maintain their OSATs, they need positive pressure ventilations, then you're probably going to have to take their airway also. And it's okay to do a Cric on these guys because you don't have another viable option in your toolkit yet. If you have a short evac time, you have less than an hour and you have a couple meds that can maintain them for that, then that's okay. But if your meds are going to run out and you took his airway, what are you going to do when your meds run out? So any other disease process that limits your patient's ability to maintain SATs or protect their own airway, whether it's some kind of cerebral disease or any other kind of thing that your guy is going to have low SATs, you're going to need to take that airway definitively, and a Cric is the way to go. So the next thing we're going to talk about is the awake Cric. This is a picture that you all should know, and you have your first vertical incision and then you have your horizontal going through the Cric membrane itself. So that's just a little anatomy for you. Before you do any of these situations or procedures, if you can pre-oxygenate, that's going to do wonders for your patient. You can do a nasal cannula at 15 liters per minute or nasal cannula at 15 plus non-rebreather at 15, and that's going to get his O2 sats way up there and allow you the maximum amount of time without doing any kind of damage to this guy's brain. If the guy has a contusion and needs positive pressure ventilations, another thing you can do is take your BVM with the PEEP valve and hold it over his face. He might even be able to do this for himself, and that way that PEEP is going to maintain his alveoli in the open position so that they're not opening and shutting and getting worse and developing ARDS in the long run. So here's a checklist we have for the awake cricothyroidotomy. Notice that you're going to have the patient sitting up, breathing on his own, pre-oxygenating until the very last minute. Make sure you can pre-treat with Zofran. A lot of the meds we're going to be giving can cause nausea, and that's just another complication that you do not want to deal with. So you can also give 1 or 2 milligrams of Versed to take the edge off and cause amnesia. You probably don't want this guy remembering this. But once you push some ketamine, 1 to 2 milligrams per kilogram, slow push, this guy is going to get dissociated and turn into a nice ketamine zombie. So have somebody behind him so that when you're ready to cut, he can lay him back, you get him in a nice position, make your cut, put in the tube. It's a very low stress procedure at that point, and it's not an emergent thing. So go through the rest of this checklist, print it out, put it up in your aid station, practice it with your guys. I'm not going to go through the whole thing because most guys are pretty comfortable with this procedure. Now, me as a medic on a team, I don't always have guys with me that are very well trained. So this is something that I might go ahead and train them on using the Bougie to correct me if I needed a procedure. So if I'm going down, I don't have an airway. I've seen my guys mess it up where they create that false passage between the trachea and under the skin, and now they're, the SATs are dropping on the patient, it's getting more emergent, the stress is rising, and you keep going along those lines, and now you're causing brain ischemic injuries. So if you go ahead and just slip the Bougie in over your knife into the trachea, into that little hole, if you need to widen it or put the tube in over it, it's going to help. So go ahead and practice this with your guys, make sure they're comfortable with it, and if this is something you practice, make sure Bougies are available either in their IFAKs or your own IFAKs so that they know where to find it and they can use it in an emergent situation. So once you've put the Cric in, what do? We've got a whole checklist here. This is also something that you should print out and put it up in your aid station or your med room. And you can go ahead and reference it whenever you do one of these procedures. So I'm not going to go ahead and read the whole checklist because we're going to go through each one of these things real quick. All right, once you have a tube in the patient's trachea, make sure it's in the trachea and not anywhere else. You don't want that false passage. You don't want esophagus, depending if you're RSIing. And you can do this with waveform or quantitative capnometry is going to be the best thing. These little purple color changing ones, if you use them, make sure you wait 6 breaths to make sure that color change actually happens. If your environment permits using a stethoscope, go ahead and use that. Although most of us are going to be in a truck or a plane or a helicopter or who knows what else is going on, if you can even hear after an explosion or gunfire happens. Okay, once you've secured that airway, you've inflated the balloon, you've made sure it's in the right place, you've double checked your placement, now's the time to double check your depth. If you used a full-size ET tube and you slam that thing down in there, you might be past the carina. So go ahead and back it out until you're just inside the incision and that balloon is just past the cricothyroid membrane by 2 or 3 centimeters. And then you can go ahead and secure it after that. And then go ahead and suture it. Make sure you have a nice good seal so the air is not escaping around it. And you treat it like any other open wound. If you go ahead and use a IV tubing or anything else to secure the tube, make sure that it's not tight around the neck and that every 8 hours or so, if you're going to be holding on to this guy for a while, that you move the position of that IV tubing because it can cause necrosis or pressure ulcers. All right, we have a sedation and analgesia paper on prolongedfieldcare.org. I recommend you read it. One thing that I would like to add is that you should go ahead and pre-treat with 8 milligrams of Zofran, or if you had to do it emergently, go ahead and give them that Zofran after you already have the tube in. And that way, it's just going to prevent that patient from vomiting or attempting to vomit, anything that you didn't get with your nasogastric tube. Okay, so you had your patient sitting up. Then you laid him down in order to do the procedure the easiest way possible. You got the tube in, you double check placement, go ahead and sit him back up. He doesn't have to be at 90 degrees like this little picture. 30 to 45 degrees is going to make his lungs work much more efficiently. It's a more natural position and it's going to be more comfortable. So this also may help ICP in head injured patients. If you have somebody that took a blast to the face, they might have ICP as well. And this is also going to help prevent microaspiration from stomach contents drifting up the esophagus and trying to get through the cuff of the tube, because we all know that we're not real great at judging the pressure in that cuff. All right, now if you put him on a ventilator, go ahead and use the lung protective strategy that the ARDSNet recommends. If you don't have a ventilator and you're going to be bagging this guy with a BVM, make sure it has a PEEP valve on it. These things are super cheap and it's going to maintain those alveoli in the open position as you bag him, as opposed to opening and slamming shut every time you give him breath. So it's going to do wonders for your patient over a long period of time. And if you go into any ICU, they're going to have PEEP on their guys that are intubated and on ventilators. All right, one thing I've noticed that medics are really bad at is making sure that that tube is clear. A lot of times we'll do a cric, we'll put in an ET tube, and even if our patient's breathing on our own, that ET tube is open to the atmosphere, and not just in a hospital sterile environment, but to the elements and to rotor wash and to dust in the back of a truck. This little heat moisture exchanger is about 45 cents if you buy a box of them. And it's going to do a couple things for your patient. The first one is filter out all that dust and debris and anything that might fall straight into the lungs of your patient. And that's something that your nose or your mouth would normally filter out. Well, now you have a tube that goes straight down into the lungs, and the patient's own body cannot do that. Another thing is going to retain the patient's own humidity and moisture in the lungs. And this is something that you can imagine in the Sahara Desert or here in Colorado, where the climate is super dry and cold, that you might end up causing some more lung injuries. And if you're in somewhere like Taylor Park where it's negative 20 degrees and you just tube this guy, you're probably going to want to maintain some of the patient's own heat as opposed to having that open to the elements. So that can remain in place up to 72 hours, or if it gets really dirty, just go ahead and change it out. Like I said, super cheap, and it's something that we really need to get and use for our patients. All right, suctioning is going to be very important, especially in those guys that had those massive facial injuries and then you laid them back for any amount of time. If you use this Ballard suction device, it's a sterile inline suction. You can keep it on there, and every time you suction this guy, it's going to remain sterile, and you're not going to introduce more dirt, debris, and bacteria into the lungs. So go ahead and hook this up. These are also pretty cheap, and hook it up to your suction. So when you suction his lungs every hour, you should be suctioning the mouth as well. And we'll get on to more oral hygiene in a minute here. All right, this is just a reminder. If you haven't hooked up your End Tidal CO2, go ahead and do it. The pulse ox, it could take 2 or 3 minutes to let you know what is going on with your patient. So if that tube came loose and you didn't notice, by the time he's desatting, you know, it's going to be 2 or 3 minutes. Whereas if you have this End Tidal CO2 and you see that that's 0, which it should never be 0, even if you're doing CPR on a quote-unquote dead guy, you should still see some kind of number on your capnometer. All right, here's where you're going to go ahead and check your ET tube cuff pressure. If it's too low, you're going to risk aspiration and any kind of pneumonia. If it's too high, you can cause tracheal ischemia and injury to the inside of the trachea, and you can imagine that's not very good. So the ideal cuff pressure is between 20 and 30 centimeters of water. It's hard to guess. Every little bulb that you're going to feel is different. There are low pressure models, there are high pressure models. So go ahead and use a cufflator and keep that at 20 to 30 centimeters of pressure. A lot of times I've heard people say, hey, why don't you just take the air out and add some saline to that little bulb cuff. Well, if you do that in real life, and I challenge you to try this out for yourself, you're probably going to end up with a bubble. And if it's inside of the patient's trachea, you're not going to know how big that bubble is. And as you ascend at altitude, if you're doing this for flight purposes, that little bubble of air is going to expand and can actually do more damage than if you just left air in there by itself. So me personally, I'm not going to be using saline in ET tube cuffs, and when I get to altitude, I'll just go ahead and deflate it and make sure it's okay. If you did not do an NG or OG tube prior to intubating or cricing this guy, you should go ahead and get it done. Make sure you suck out the stomach contents and decompress whatever's in there. Make sure everybody that you're working with knows exactly what to do if something happens, such as a rising end tidal CO2 or a falling pulse ox, or what happens if there's a change in the respiratory rate. Make sure that everybody, even if they're not medically trained, can see in big letters what these parameters should be and what to do if these go out of whack. It's probably going to come wake you up, and then you'll have to deal with it. But that's okay as long as the patient's getting the best care. All right, once you have the tube in, you can go ahead and decontaminate the mouth with the oral chlorhexidine. We got this from our dentist, and it works great. You can go ahead and swab it out, and every 4 hours you can brush their teeth, and then the other 4 hours you can swab. So you're going to be doing something for this guy's mouth, and that's going to reduce the risk of the pneumonia and everything else. And don't forget chapstick or Vaseline for the lips. So there's the checklist. We did all those things. If you want to check out more about this stuff, I really recommend Scott Weingart's EMCrit podcast number 84, post-intubation package, where we got most of this from. And then you have the tactical airway algorithm in black. That's going to be available for download in the show notes. And then you have our own prolonged field care working group airway recommendations that you can download and read, and I recommend you do that. We also have a paper on why we need PEEP valves, so you can read that. Phil Mason wrote that for us. We have our sedation and analgesia recommendations, so there are a lot of resources and references here, and they're really great to read. They're not long. They're not like 50 pages each. They're usually 2 or 3 pages at the most. And then at the very bottom, we have the University of Cincinnati and U.S. Air Force Sea Stars paper on the ET tube cuff pressure, which recommends all the things that we did here. So that's it for this episode. If you have any more questions, go ahead and put them in the comments of the show notes on prolongedfieldcare.org, and we can go ahead and answer them. We have so many people that follow our website, from medics to doctors, and we can answer any question you have. Or if you need to know where you get those things, just rewind this video, go back to the reference number for the HME or the Ballard inline suction, and make sure your MedLog guys are carrying those. So thanks a lot for listening. Bye.